Hello, my name is Tom Bartholomew. I'm with Rutgers University, and Rutgers University partnered with the Division of Mental Health and Addiction Services in the development of a project on inpatient violence and the prevention of inpatient violence. This video is called 3 Steps to Safety, and it'll walk you through some of the science of inpatient violence and its prevention, as well as some techniques that we hope will help prevent violence. This project owes some gratefulness to Dr. Maria Kirchner, who is the chair of the Violence Prevention Committee that helped develop this project, as well as Joe Berkman, the head of the state hospital affiliation with Rutgers. Also, I'd like to thank Eugene Calvin, who helped give very good feedback on this project and is helping with this video. So, after an extensive review of the literature on inpatient violence, some things were found that we're going to be using to develop this project. And this project focuses on a very specific type of inpatient violence, which is the violence perpetrated by patients on staff. There are, of course, other types of violence, patient-to-patient violence, for example. And so it's understood that this project does not attend to every type of violence that's out there. So the germ of the idea for this project comes from a fellow named Vikram Patel from what's called a TED lecture. TED lectures are lectures that refer to technology, education, and design, and they're available online. You can look them up. This lecture had Dr. Patel describing a project in Pakistan and India and Northern Africa in which a great number of people were suffering from mental health issues, including post-traumatic stress disorder, depression and anxiety, and the like. And Dr. Patel wondered if it was possible to do what he called task shifting. And task shifting involves packaging very complex clinical interventions in ways that smart lay people can provide them. And so he did this and ended up studying these interventions and found that in fact they were very effective and helped a great number of people. He called this approach Sundar, and Sundar is Hindi for attractive, and it's an acronym, and it stands for, the S is simplify the message, so we want to remove the psychobabble and the jargon. The U stands for unpack complex interventions, and we'll describe what that means. But it's the idea of like what are the mechanisms of action that make the thing work. D, deliver the intervention where it's needed. We'll describe what that means. A, make it affordable, and in our case, it's, other than the cost of this training, it's free. And R, reallocate professionals to capacity building and supervision. So in Pakistan and India, for example, there are very few psychiatrists, and there just simply weren't enough for them to go around. They had 100,000 clients each, imagine that. And so they can then move to working on task building and training and supervising efforts like that. All right, so what are some common Sundar interventions? They're around us all the time. And so one very common one is called cardiopulmonary resuscitation, or CPR. And it's so common that we don't think of how complex it is. But it's a good example of a Sundar approach. Another one is abdominal thrusts, used to be called the Heimlich maneuver. And so you can see, if you run through the Sundar acronym, they've simplified the message for CPR, for example, where we're going to breathe for the person and we're going to compress the chest. We've unpacked the complex interventions so we don't have to rub the person's feet, for example. I think it's not going to help. We also deliver where it's needed. So somebody that requires CPR, we don't drag them to the emergency room for treatment. We do it right where they require it. It's very affordable, with the exception of the cost of Resusci Annie, the doll we use for CPR, and the cost of trainings and getting people to trainings. And then we reallocate professionals, so we don't have paramedics doing this. They can go off and train people to do CPR and the like. And you see on the slide numerous other examples of Sundar interventions. There's probably others that I couldn't think of. All right, so what's the Sundar for violence prevention? And that's what we're going to spend the bulk of the rest of the training on. So let's begin to unpack the issue of inpatient violence and start with the prevalence. So the chance that the average psychiatric facility staff member will be assaulted is about 1 in 3 per year. So I think Trenton has 1,200 staff people, so you can do the math. That's a good number of people. And it's a very high prevalence. And the risk of injury in public mental health hospitals is greater than the injury rates for agriculture, mining, manufacturing, transportation, and construction. Wait for it, combined. So this is a very important subject, and should be important to all of us to do what we can to prevent inpatient violence. All right, so continuing the unpacking for a moment, a fellow named Cameron Quanbeck did a study where he tried to look at the taxonomy of inpatient violence, and he identified 3 types: instrumental violence, psychotic violence, and reactive violence. So instrumental violence is violence committed to accomplish something. So I'm going to be violent so that you give me privileges, for example. I'm going to try to accomplish a goal. And you can see on this slide that in forensic settings, about 29% of over 800 violent events in this study were found to be or identified as instrumental. And about 20% in civil hospitals were found to be instrumental. So somebody wants to go on a fresh air break and they threaten you and that you let them out. That's the function of instrumental violence. He identified the second type of violence as psychotic. And this is violence committed due to distorted thinking, or the person is afraid. And we see this with folks who think they're being poisoned or think you're trying to hurt them. And again, if you look to the right on the slide, you'll see that Dr. Quanbeck identified 70% of violence in his study in forensic centers as psychotic, and a little less in studies of civil hospitals. And here's a really important part of the taxonomy, where he identified reactive violence, which is violence that is committed as a reaction to perceived provocation. And this could be the person is told that they can't leave to go to the trading post, or they can't have a television in their room, or whatever it is, and they react negatively and maybe in a violent way. And in Quanbeck's study, 54% in a forensic setting of the violence that he identified was reactive. And in civil settings, it was much higher, and 65%, which is a large percentage, well over half, was reactive violence. And this is really important for our Sundar, because this is what we're going to attack and try to do something about. Instrumental and psychotic violence have other effective interventions, which we may cover in future trainings. But this training, we're really going to focus on reactive violence. So this slide is a little complicated, but the way to think about it, this dotted blue line that runs horizontally across the slide is a threshold above which violence occurs. And the blue part of the slide represents patients' biological predisposition or historical predisposition to violence. And so, as you can see, if each bar represents a different patient, some patients are kind of lovers, not fighters, and there's very little you could do to provoke them into violence, and that's true in society in general, that some folks are just not violent. Other folks, including patients, may be predisposed to violence, and so their blue line can be very close to that dotted threshold, that dotted line, which represents the threshold for violence. And so the last part of this slide, the red, is what we contribute. It's what we bring. So it could be environmental things, or it could be behaviors, staff behaviors. So we could make the environment very hot, for example, and very crowded and very stressful, and we could yell at patients, and we could make high demands on patients, and add a great deal of the red part and really bring them above the threshold. And so from this slide, you can get a sense that even if we don't intend to provoke violence, we might do it inadvertently because our systems or the physical environment is such that it's not conducive to being calm, for example. So this next slide is a very complicated model of inpatient violence. And what it says is that there are three major drivers that we're concerned with, which are patient characteristics, environmental characteristics, and staff characteristics that can all combine and interact in ways that can lead to violence. And in this complicated slide, you see on the right other patients and visitors. So there's certainly the very real patient-to-patient violence or visitors that come in and either set the patient off or are themselves violent, which does happen. But this model is very complex for our needs, and remember what we're doing is simplifying and getting rid of jargon. And so here's the model without all the explanations. And again, you see we're going to be talking about what do patients bring to situations that can lead to violence, what does the environment lend to things that lead to violence, and what do staff bring that leads to violence. So in terms of patient characteristics, the science is very clear that a history of violence is the best predictor of violence, which makes a lot of sense, right? If somebody is violent prior to admission, they might actually be admitted because they're violent. And it's the best predictor going forward. As is age, which is younger, being male, being poorer, having a diagnosis of paranoid schizophrenia or certain types of personality disorders are associated with increased levels of violence. But if you think about it, patient characteristics are what we call static in the sense that the person's history isn't going to change, at least not in the short term. Their age won't change dramatically in the short term, certainly the others in a similar way. And so this is not a good place to spend our time in terms of trying to intervene. Environmental conditions can have powerful effects on patients and staff. And the research suggests that very noisy, crowded, high temperature or low temperature can have a negative effect on both patients and staff, as can a staff-patient ratio. So there's evidence that if you have too few staff, that can be a problem, or if you have too many staff, oddly, that seems to be a problem as well. One of the largest and most recurrent elements of the environment associated with violence is poor structure. And this can have to do with if patients don't know what to expect or it changes every day, this is a pretty bad sign. And in studies where they see cycles of violence, it's often the case where once violence occurs, the structure falls apart because the staff are understandably attending to the violence. But then you can see a cycle and kind of a contagion effect. So it speaks to, even if there is an event, something needs to be dealt with to try to maintain the structure despite that. Also boredom, and when expectations are too high, these things are also associated with patient on staff violence. All right, so we attended to two of the model's components, the patient characteristics and environmental characteristics. So now let's talk about staff characteristics or staff factors. These are things that staff bring to the incidence of violence and may lend to the provocation of violence, even if it's not intentional. And so in a review of 30 articles from the 70s to more recently, 2014, a number of staff behaviors were identified as related to patient violence. And in this slide, you see many of them listed, and to the right, you see the number of articles that reference them. And so things like staff expressing anger, staff when they avoid patients, when staff are highly anxious or fearful, when staff externalize blame onto patients. In other words, violence is all about patients, and that's they're the cause, and really staff behavior has no effect. When staff believe that, not a good sign. When there is poor communication, poor alliance, and then you can see here controlling or authoritarian behavior was associated in 14 of the 30 studies with patient violence. And so this is an important factor. And it begs the question, what do they mean by controlling and authoritarian? Because it's in large part the job of staff to control the environment and control what happens and to exercise some authority. And what we'll find as we go along is that there's a way to maintain control which is much less provocative and ends up kind of building relationships and improving communication. And that's largely the focus of this training. And then the last two, inconsistency of rules and a violation of rights. I think people would see that as those two as associated. But one of the jargon, part of the jargon in the literature is something called procedural justice or procedural injustice. And this patients are very sensitive to. So for example, if one patient is allowed to go to the trading post or the store on the hospital grounds and another is not, patients find this very upsetting, understandably. Particularly if they don't understand what the difference is, like why can this person go and I can't? Okay, so in a very important study that came out of England, this woman, Joy Duxbury, found that patients and staff have different ways of understanding violence on units in psychiatric hospitals, and that staff generally believe that patients are the cause of violence. So when staff are surveyed after a violent event, for example, they'll say, well, the patient is ill and they're, this is why, and they have a history of violence, for example, and this is why violence is occurring. Whereas patients, when interviewed, indicate that staff behavior was the root cause or they felt provoked. And very important about this idea is that when external observers are on the ward, they tend to agree with the patients that really the violence often happens as an interaction between staff and patients. It's not to blame staff for violence, but it speaks to the fact that staff behavior can interact with patient behavior in a dynamic way that leads to violence. Okay, so some other ideas as we continue to unpack, and eventually we'll finish the unpacking and move on. But it's important to think about this idea called diagnostic overshadowing. And diagnostic overshadowing is the idea that if somebody is diagnosed with schizophrenia, it doesn't mean that if they're also violent, that it's because of the schizophrenia. That there's very good evidence that people with schizophrenia are often not violent and are more often the victim of violence. And so diagnostic overshadowing is the belief that if a person is diagnosed with schizophrenia, that that's the reason for the violence, whereas obviously there can be other reasons. So in a very large review of inpatient violence, over 1,000 studies, Len Bowers and his colleagues at City College in England identified 3 staff-patient behaviors, or behaviors that staff are engaging with patients. And that these 3 behaviors were associated with over just about 65% of reactive inpatient violence. And the 3 behaviors are limit setting, activity demands, and denials of request. So if you're working on a unit right now, I suspect you're nodding your head because these make a lot of sense. If you're telling a patient that they have to stop doing something, they have to stop screaming or stop doing whatever they're doing, or if you tell them it's time they took their meds, time they got into the shower, or time that they went to group, or that they can't go on a visit with their family, or they can't go to the canteen or the trading post, that these are potential triggers for inpatient violence. And it's important to note that staff, in this case, are not intentionally provoking patients. They can, in fact, be doing exactly what their job tells them to do, which is I need to set limits, I need to require patients to do stuff, and I need to deny requests. Like, for example, if a patient says, you got to let me out of the hospital, I need to get out of here and get home, you can't let them, you have to say no, right? You have to deny that request. So all three of these staff-patient interactions can be made worse if the patient perceives procedural injustice, as I mentioned before, where, well, you let this person do it, but I can't do it. So it's something to keep in mind. All right, so based on this unpacking, this idea that staff and patients see things differently, that patients often feel provoked into violence. And remember, that doesn't mean that the staff are intentionally provoking anyone or that staff have done anything wrong, but this is what the patients tell us when they're interviewed about violence. So based on that, how might we design an intervention to prevent particularly reactive inpatient violence where patients feel provoked? And so the intervention is called 3 Steps to Safety and involves a 3-step process, and it's intended for use during activity demands, denials of request, and limit setting. It's also intended to be used as a general rule and not as a de-escalation strategy, at least not solely as that kind of strategy. So the 3 steps are validate, explain, and problem solve. And we're going to take a few minutes just to go through each one of these steps. The first step is called validation, and admittedly it's the most difficult of the 3 steps to do and to understand. A lot of people say, oh, I validate all the time, but if you watch them and you try to discern when are they validating, it can be difficult. So what is validation? The book definition is a communication skill that conveys an interest in understanding another's feelings and point of view and attempts to normalize those feelings within the current situation. That's a mouthful right there. So what does this mean? So the idea that if somebody engages in a behavior, can you communicate that there's something about that behavior which is normal that you would agree with? And can you communicate that to the person? So I'll give you an example. Years ago, I was a consultant at another psychiatric hospital, and there was a girl that had a cast, a patient that had a cast on her arm, and she was picking the cast apart and throwing the pieces on the floor. And a staff person came over to her, and apparently they had had a long relationship and a pretty close relationship and trusted one another. And the staff person apparently had told her not to do that before and was very frustrated and put her hand up and said, that's it, I'm done with you, and walked away. And the girl with the cast, who had a long history of being aggressive and violent, appeared to be stewing and be growing increasingly angry about the interaction, and eventually smashed her cast and her arm against the nurse's station, the plexiglass, and ended up breaking the mounts on the nurse's station. And she was eventually restrained. And this was very informative to me. I went and looked up the incident report, and what it said about the cause was there was no known cause. It was attributed to her being very ill, and she was ill. But it's a good example of an external observer seeing something different, right? So I think the cause was this interaction. I'm not blaming the staff for it. But if you were to do a validation of that interaction, what might you say? So you could say, listen, if somebody said that to me or if somebody put their hand up to me, I would be really upset too. I wouldn't smash my hand against the nurse's station or potentially break my arm again. But so there's an example of a communication skill that conveys an interest in understanding another's feelings. So I care about your feelings. I would feel the same way if somebody did that to me. And that there's something about it that's normal, that we would all feel that way. It's not because you're in a psychiatric hospital that you feel that way. So, but in that example, there's another important idea, which is you don't want to validate the unvalidatable, right? So you don't validate her hurting herself or breaking things. You validate the feeling. Yeah, I would feel the same way, but that's a normal feeling given what happened to you. You can imagine doing this when somebody's family member calls them and says something very upsetting, that you can say, listen, I would be really upset too if somebody told me that. That's a normal feeling. I'm not going to talk you out of your feelings, and I'm not going to punish you out of your feelings, nor am I going to just ignore your feelings and tell you to be quiet and sit down. I'm going to validate that experience. So that's the first step, that if we can validate, very often it's you hear kind of a tss, where you hear and feel the tension leave from the person. They don't have to convince you that they're justified in being angry. You're telling them you get it, and that you would be angry too. The next slide speaks to this idea of how we can validate, and it's called the client-centered approach. And on the slide, you can see the counselor on the left, a silhouette of the counselor on the left, and a silhouette of the client on the right, and they look really similar, actually. And in this case, what we're trying to get across is, can the counselor see the world through the client's eyes? And if you're willing and able to validate, that's what you have to do, right? So I look through the girl's eyes with the cast and attempt to validate her by saying, yeah, you know what? If I were in your shoes, I would feel the same way. It's a very powerful type of communication and a very powerful skill that staff can bring to bear. The second step in the 3 steps to safety is the idea of explaining the reason. So remember, we're using this strategy primarily during activity demands, denials of request, and limit setting. And so we want to explain the reason. Why is there a limit set? Why is there an activity demand? Why are we denying request? And it seems very straightforward, but sometimes when we're very time pressured, we're very busy, we just don't do it. And 2 things we want to get across. The first thing is that it's not personal, that we're not saying that you can't go because I don't like you. We're saying you can't go because maybe you're not on the right level or whatever the reason is, but it's important to give the reason. All right, so that's step 2, explain the reason for the activity demand, the denial of request, or the limit setting. The third step, the 3 steps to safety, is to problem solve. And here again, there's two things we want to keep in mind. The first thing is we want to problem solve if the person is still upset, because even if you validate and explain why, it doesn't mean the person's going to be happy and completely calm. And so the first thing we want to do is problem solve. How can you feel better? How can you kind of relax? And oftentimes we have personal safety plans to pull on, or we can just talk to them and negotiate. Like what would be helpful given that you can't go to the trading post or that you can't go home on your visit or whatever it is. And then the second thing we can do around problem solving is how can we actually get you to the trading post or get you to the visit or get you to be able to do the thing you want to do. Okay, so seems pretty simple, right? 3 steps to safety. And we're going to be showing some videos. And in the videos, we offer what's called an observation checklist, so that anybody watching the video or watching an interaction of a staff with a patient can score the staff person in their ability or their willingness to use 3 steps to safety. And this observation checklist was used by experts watching a bunch of snippets, and we found that in fact the checklist was fairly reliable. It means that I saw the same thing as my colleague, and we did these ratings independently. So the checklist goes from a low number to a high number. The high number is better because it represents more 3 steps to safety was present. And so what is the checklist about? In the first one, we want to rate whether the person validated or not. And so you'll note, if you have a copy of the observation checklist, that it's possible to be invalidating. It's possible to say, you shouldn't feel that way, or zip it, I don't want to hear it, or be quiet and sit down. In essence, I'm not going to look at the world through your eyes, I'm going to tell you how you should feel, which is the essence of invalidation. And that would be scored a 1, because there's no element of validation there. Number 2, as you can see, involves, you might be very nice to the person, you might be very motherly or fatherly or brotherly or sisterly, but you're not necessarily validating. So it's certainly better to be nice, but it isn't the level 3, it isn't actually the validation that 3 steps to safety is encouraging. And that would be scored a 2. The third possible rating for validation would be the person actually validates and normalizes that behavior in the current situation. And that's, of course, what we're looking for. So that's how you would rate validation. The second rating involves explaining the reason why. And again, you can see the anchors there. It's pretty straightforward. The person, a 1 would be they didn't explain the reason why, or gave the wrong reason, because I said so, because I'm bigger than you, might be examples of wrong reasons. All the way up to a 3, where they really made an effort to explain the reason why. The third step to safety on the observation checklist involves problem solving. And here again, a 1 would represent where there simply wasn't an effort to problem solve. And the anchors for those 1, 2, and 3 move up to a 3, where you see the staff person problem solving and ideally working with the patient to help problem solve, because we want them to learn that skill of identifying what could they do to get what they want and to be calm if that's what's necessary. Now on the observation checklist, there's a 4th thing, which isn't one of the 3 steps, but still is important, and it has to do with essentially body language, nonverbal communication. And in this case, what we're looking for is body language, nonverbal communication that's consistent with a supportive therapeutic relationship. So we want it smiling, eye contact, an open posture. And so when you see that, that would be rated a 3. If you see the staff person seem threatening, seem intimidating, that would clearly be a 1. So we encourage you to check out this observation checklist. And when we do, we're going to be showing you a number of videos, and we would like you to rate those videos using your observation checklist. There's 2 versions. One is to rate 1 interaction, and hopefully the one you have has multiple observations. So each column represents a different observation, and you can put the score for the validation, for the explaining why, for the problem solving, for the nonverbal communication in the first column for the first video. All right, so we're starting up a number of videos. Have your observation checklist handy and prepare to rate these videos as they play.
Hey, Ty, you unlock this? I can use the phone?
Man, it's 2 a.m. There ain't no phone calls this time of night.
Yeah, but it's very important, man.
2 a.m. No phone calls.
I'm a grown damn man. You on your phone all night.
Man, you're gonna have to stop worrying about what staff do and worry about what patients are supposed to do. It's 2 a.m., man. Go ahead, take it back.
This guy go again, man. Every night is something new with you, man. What's going with you now? Every night is something new.
Okay, so you just saw the first video, and of course the guy on the couch was the staff person, and the guy walking out was asking to use the phone. And so if you were to rate whether the staff person validated the patient's perspective, what would you say? Does the staff person know why the patient wanted to use the phone, for example? All right, so you might rate that a 1 because the staff person never found out why the patient wanted to use the phone. And really the issue was, you've got to stop doing this behavior. All right, so validation, you would score a 1. Number 2, explain the reason why. Now here, the staff person did explain the reason why. It's 10 o'clock or whatever, it's 2 o'clock in the morning, no phone calls. And so even though it maybe wasn't done in a particularly therapeutic manner and it wasn't associated with validation, there was an element of explaining why. And so you might rate that a 2, you might even rate that a 3. The point of this exercise is not to get the perfect rating, but to really start to see interactions in this 3-step way and be able to talk about them and the value of the 3 steps. The question about whether the staff person problem solved, it did not appear that there was a lot of problem solving going on other than you need to go to bed, this is inappropriate for you to be up. So that likely would be a 1. If you have other ideas about any of these ratings, that's absolutely fine. There's no perfect answer. And then nonverbal communication, it was interesting that the staff person got so close to the patient and really created maybe a dangerous situation like that. All right, so that nonverbal communication would likely be a 1. You could argue for a 2 perhaps. All right, let's watch that same scenario in a second video, and we'll do the same thing. We're going to rate them on the same observation checklist, the 3-step observation checklist.
Hey, Tom, can you open the door, man? I got your phone. Hey, what's up, Eugene? It's 2 o'clock in the morning, bro. You know when we calls up. Damn it, man. Let me use the phone. Oh, I can see you upset, but what's going on?
I got family issues.
Oh, you got problems with the family?
Yes, I had to call my uncle, man. My mom is sick in the hospital.
Your mom's sick in the hospital. I can see that's upsetting you, but it's it's still after 10 o'clock. There's not much we can do about that tonight. I mean, I know that's messed up.
Hey, Tom, what's going on? I see Gene is upset.
Hey, what's up, Phil? Yeah, I was talking to Gene. His mom's in the hospital, and it's apparently he was trying to call his uncle to get some information. I'm assuming. I was telling him it's not much we can do about that because it's after 10 o'clock, but definitely can help him out in the morning with it.
Yeah, I'm sorry the way you feel about that, but that's something we can't really do right, tonight. But tomorrow morning, I think first thing tomorrow morning, we'll have first shift come in, have you meet with the social worker, call your family to see if we can resolve this issue, see if you can get some relief from this issue.
Man, this fucking place sucks, man.
I'm sorry you feel that way.
Yeah.
Gene.
Fuck, I can't wait to get the fuck. All right, that bullshit be on.
Okay, so in this video, very different situation and different outcome. So the question, the first rating of validation, did the staff person see the world through the client's eyes? And how would you rate that? All right, when we do this rating, we see that as a 3. And one thing that the staff person says is, yeah, that's messed up. Meaning, I would want to call my family too to get an update on a sick relative. So then rating the second step, did he explain why? He did explain why. It was very similar to the first video, but there was certainly seemed more therapeutic and there was less intensity. And so that, you might rate that a 2 or a 3. And then lastly, did he problem solve? And here the other staff person came in and helped, but there was a problem solved. And maybe they could have encourage the person to participate in the problem solving, but in any event, there was problem solving happening. So that, you might rate that a 2 or 3. And then nonverbal communication, certainly better. They kept their distance. They seemed open, and they seemed genuinely concerned and supportive. And so you might rate that again 2 or 3. Now, it's important to note from these two very similar scenarios that in the first scenario there was violence, the chair was thrown, and who knows what happened after the tape cut off. And in the second video, the patient was still very upset and kicking a chair and slamming the door, but it didn't lead to violence. And it's the opinion of many people who study this kind of thing that that's a more realistic outcome of using 3 steps to safety. It's not that the patient is completely happy and you hug it out and everything's great, but that there's just less potential for actual violence, which is what we're looking for. All right, so let's watch another series of videos. And this one has to do with an activity demand and taking medication.
Is that everybody?
No, we have one more, Tom. He's been refusing for the past couple of days. Let's try to get him up for his meds.
Okay.
Thank
All
you.
right. Tom, the nurse needs you to take your meds.
Leave me alone. I'm not taking no meds. Leave me alone. Leave me alone.
Come on, let's go take your meds.
I said, I ain't taking no damn meds. Get the hell out of here.
All right. They're going to give you a needle if you don't take your meds. Let's go. You got to take your meds.
Look, I'm not taking no damn meds. I'm not taking no needle. You get the hell out of my room before I wind up hitting you inside your damn head. Leave me alone. I told you once.
Tom, I'm serious. Let's go.
All right, in this video, the young woman comes in to ask a patient in bed to get up and take their meds, and as you could see, it didn't go particularly well. And so let's use the observation checklist and rate the 3 steps to safety. So the first rating is validation, and the question about whether the staff person saw the world through the patient's eyes, an attempt to normalize that patient perspective in the current situation. Not appear that that happened, and in fact the staff person appeared to be threatening the patient with getting a shot of medication. It didn't seem particularly relevant how the patient felt or the way the patient saw the world or what was going on. So in the first rating, it would likely be a 1. Rating the second step, explaining why, the staff person really didn't explain why, other than it's just an expectation that you take your medications. So again, likely the score would be a 1. Maybe you could argue for a 2 if you see it a little differently. The third step, did they problem solve? Again, the problem solving seemed to be, we're going to give you a shot. So that's a pretty ineffective way to problem solve, and we would likely score that a 1 as well. In terms of nonverbal communication, the last thing scorable on the observation checklist, it's a little difficult to tell, and maybe it's not possible to rate, but the staff person was holding the clipboard against their chest, and the patient wasn't particularly in a position where they could benefit from good open posture or eye contact and that kind of thing. So we may not score it or scored a 2. Okay, so let's watch this scenario again and see if this second attempt at an activity demand can be done differently.
Tom, the nurse needs you to take your medication.
Leave me alone. Leave me alone.
What's the problem, Tom? You normally take your medication with no
Leave
problem.
me
What's up?
alone. Leave me alone. I'm tired of them damn pills. I'm tired of taking the damn pills. You take them.
Well, I see you upset, and I've noticed that you kind of changed a little bit, so tell me a little bit about what's going on.
Well, pills make me sleep all day, man. I can't do anything. I'm just tired, and I'm just not taking them anymore. I'm not taking them. So just leave me alone.
So your meds is making you tired, huh? Okay, all right. So tell me a little bit about how you feeling. Are you getting a little groggy? Like, what's the problem though? Like, tell me, like, what's a normal day like?
I can't really do anything. I mean, I just sleep all the time. I have no energy. I just don't want to do anything. I just can't take them pills. I'm not going to take them anymore. I just can't. I'm just not. You can tell anybody. I'm just not taking them no more. I'm not doing it.
Did they change your medication? Did they change them?
I'm not taking them anymore because I'm just not going to do it. Just leave me alone. I sleep all day. I'm tired. I just can't get up.
Okay.
I'm going to go to sleep now.
Okay, so your meds are making you tired. So how about when the doctor come in tomorrow, you talk to the doctor about how you feel and it's making you groggy? Because I can understand. I wouldn't want to take nothing that makes me sleepy all the time. So tomorrow, how about tomorrow you talk to the doctors and see what they can do about maybe adjusting your medication, changing it or taking it, doing something different.
All right, look. I'll do this. I'll talk to the doctor.
Okay.
I talk to the doctor. You set it up or tomorrow, but I'm not taking the medication. I'm not taking that medication. I'm not taking the meds.
All right. Okay. Let me go talk to the med nurse and let her know what's going on and why you don't want to take your meds.
All right. Thank you.
Okay.
Thank you.
Okay, so obviously a very different outcome from the first video, and let's run through the observation checklist. So question the first step, rating the first step of validation, does the staff person know what the patient is seeing, what the patient's worldview is, how the patient sees the world? The answer to that is yes. The patient took the time to ask what it's about, what's going on, what's a day like, and the patient was able to tell her. And so from a validation point of view, that was pretty good. She actually said, yeah, I wouldn't want to take medication either if it made me feel so sedated or so ill. So we would score that a 3. That's a good job at validation. The question about explaining why, we didn't really see that very much. We didn't see why he should take medication or why he should get up and do that. And so we would probably score that a 1. Good example of it may not have mattered that much. The validation was so key. For step 3, problem solving, she did problem solve, and he even participated a bit, and he said, okay, here's what's going to happen, blah, blah, blah. And so we would score that a 3. Lastly, nonverbal communication. Again, it's a little unclear in these scenarios. So without knowing any more, and it certainly was not, she gave him space, that was important, so we may score that a 2. But you could argue either way. So what's important about this scenario and the other scenario, the first scenario, where we saw the video, was in neither case did the patient, well, at least in the first case, the patient didn't get to use the phone, so the limit setting and denial of a request was effective. And in the second case, he didn't take the medication, but there was no violence in the second, the last video we saw. So that's a really important thing to note, is that 3 steps to safety is not about manipulating patients to do what you want, but it's really about not inadvertently provoking violence and adding to the patient's potential for aggression or violence. All right, so those are the 4 videos. The last part of the training, I just want to talk a little bit about what we call implementation. So the question about how can we use 3 steps to safety effectively in the hospital. And in this slide, you see changing practice, the train and pray solution. And so the science of trainings is that when people attend a training, they tend to know more about the subject, but they rarely change clinical practice. And so based on that, we have to do more than just a training and hope that things get better after the training. And the thing we can do is use a type of supervision called clinical supervision. And it's important to note, many people think of supervision as a bad word. It means somebody's going to wag their finger at you or give you a demerit or write you up. But the history of clinical supervision is that it comes from England, and it started as a way to try to support staff and particularly nurses in their very difficult job of caring for patients. And so there was a large part of clinical supervision that was supportive, intended as support. It was only after its import to North America that you started to really see a high prevalence of snoopervision, of seeing supervision as, I'm going to watch you and catch you doing something wrong. And so this tension began to develop between supporting someone and holding them accountable. And that's the challenge of good clinical supervision. So we're using what's called the alliance model, which has 3 functions. And the 3 functions are restorative, formative, and normative. These are 3 functions of clinical supervision of this model. The first function is what I described earlier, is supporting staff in all manners of ways. So we can do team building, we can do self-care, we can talk about job design, how you do your job in ways that are more rewarding and less dangerous, perhaps. The second function of clinical supervision is formative, which is the idea of, can we all learn new skills so that in 20 years, we're 20 years better at our work than we were 20 years hence previously. And then lastly, the normative function of supervision is accountability to ethical and professional norms. And this is an important function because in the end, we simply cannot harm patients. We can't take their money, do things like that. It's simply unacceptable, and that is part of clinical supervision. So as you can see, the challenge is to stay safe and supportive in the clinical supervision relationship, while at the same time holding people accountable for their work and for their behaviors. So these 3 functions are very important. And specifically, when discussed in terms of 3 steps to safety, the intent is to employ what's called audit and feedback. And on this slide, you can see in the Cochrane Collaborative, there were 141 randomized controlled studies on this practice. And what that means is it has a lot of science backing it up. And what audit and feedback is the idea that if you get feedback about what you're doing, if somebody watches you interact with patients and gives you feedback in a supportive way, in an effort to help you be safer and better at what you do, it can be very, very helpful. And this is, the idea is to use the observation checklist to first do an audit and then offer feedback, again, in a very supportive way for staff on the wards. So 3 steps to safety has been studied in a number of pilots. And on this slide, you see a reduction in violence on an admissions ward. And what's interesting is the reduction was so significant that it got down to near 0. Now, was it completely the product of 3 steps to safety? We don't actually know that. These small studies, it's hard to make these kind of causal inferences. But it's still, nonetheless, encouraging. In the second pilot, there was a reduction of 40% of restraints were reduced by 40% during the pilot, and that was maintained through the 6 months of the pilot. So it should always be noted that these claims like this should be treated with some skepticism. These are small studies, and inpatient violence is highly dynamic. So there could be other phenomena occurring. We did control for very violent and restraint-prone patients and whether they left during the study or just prior to the study, that kind of thing. And that did not appear to be the case. In fact, in the study where there was a 40% reduction, the patient that had the most restraints also saw a reduction in restraints. So that's again a positive sign. So here are the references. I encourage you to read them. And thank you for participating in this training.